Today I'm presenting a case of a rock climber who presented with a ulnar collateral ligament injury to his distal interphalangeal joint of his index finger 4 months ago. Today it will be his 4th treatment. I'm really excited about being able to offer focused shockwave treatment for this type of presentation, simply because in the past our interventions just weren't helping sufficiently enough for this type of injury. And there were quite a few cases, there's a few cases I can remember in recent times where we didn't help the patient at all and they really did have to just give up and decrease their effort in climbing. This year now, this is the 4th case of a collateral ligament injury of the PIP or the DIP that we're treating that seems to be moving on towards resolution. So one of the first things I look at with these finger injuries is the range of movement in flexion. So we have the MCP here in hyperextension and we see if the pad can oppose the distal palm there, so that's holding there. When we first started treatment that range was not available, so that's significantly improved. Then we look at strength of the finger flexors in particular in different positions. This is a great position to start in, so keep the MCP in full extension. This is not the injured finger, this is the 5th. So hold your pad into your palm, see that's good. Onto the finger that's actually injured, the ring finger, hold the pad into your palm. Good, see that's a lot, that was failing on initial consultation. He wasn't able to hold that. That is significantly better. Now the other position that I tend to test in is with the arm out straight, finger, and then pull. So we're testing finger flexion with the MCP at 90 and the others in neutral and hold, and that was failing day 1 and there was significant pain. Obviously palpatory assessment, the palpation over the area, and I'll normally have the palm down to feel, and this is all supported by ultrasound scanning, so I'm a MSK sonographer. So we start off in pretty much pure sagittal plane. We can see on screen that there's no look of disruption there, it looks absolutely fine. As we go around the joint, keeping the joint in the middle, one can see, especially at the distal end of the middle phalanx, looks to be a bit of disruption, a bit of cortical disruption in the scoop. That's the origin of the ulnar collateral ligament. So the first important factor with focused shockwave therapy is understanding the depth that one is treating. So we're going for a superficial penetration. So we're using the most superficial of the attachments here, which is going to give us a 5 millimeter cavitation. So we'll apply that now. And first treatment, I'm looking to hopefully achieve 2,000 pulses. I tend to use frequency of 6 Hz simply because we find that 6 Hz gives a reasonable speed of treatment, but the actual sound wave, the shock wave, is actually really able to form properly. So we've got the 5 millimeter head attached, so I'm going to apply it to the area of the actual injury, and that's been confirmed by palpation as well as sonography, but we're also going to get lots of patient feedback. Now, we're going to start this, the intensity is at 2 there, so we're just going to start the treatment. And keep in mind this is the 4th treatment, so the patient is going to tolerate a lot more than did day 1. Day 1, my records show that we got up to 3 maximum. Now can you feel much there? Not much, and we're not expecting last time, so we're going up to 4. In all probability, the practitioners watching this will not go beyond 3 to 4 out of 10, but you'll see here, because it's almost like the nervous system entrains to tolerate what you put it through. So this patient, he was actually tolerating 7 out of 20 on that intensity scale, and that's rare for fingers. But if everything seems okay, it's absolutely fine as long as you're monitoring the situation. So up to 5, I expect you're feeling something now. Starting to feel anything there?
Not much.
Okay. So I'm going to go up here. Did you remember how it was first time? It was like pretty much immediate. How does that feel there?
I just can't feel anything really.
Can't do anything?
Yeah, that's a bit, oh yeah. Whoa.
Okay. Is that score out of 10?
It's gone again now.
It's gone, okay. So we've performed 2,000 pulses with the palm down. So can you just turn your palm up now? So we're going to now decrease the power because we're going for a different angle. So we're hitting the same tissue, but just from a different angle. We're just making sure we're covering every possibility to try to optimize the benefit of the treatment session. So we're going to start from there. We pretty much expect that we're going to be turning it up fairly quickly, but we don't actually know. So we have to monitor things again. So we're still on the ulnar collateral ligament, but just going on from a slightly different angle. So I'm on my tiptoes there, I've got my hands over the hole, and I'll just take my full body weight there. And it's about a 15-second hold. And then I'd rest for 45 seconds. I'd repeat that 3 to 5 times. Maybe then rest for 5 minutes, then repeat that cycle. As things improve, then you can sort of see that you can go on to smaller holds. So then I might go on to something like this in about 2 weeks' time, following a similar cycle. But I would look to be doing some loading like this on a daily basis to help the finger. So it's a matter of finding the point which your finger tolerates. You want to keep it relatively pain-free for this exercise.
Yeah, at the first treatment, it was quite painful, and I was struggling to do any training at all. Now, after the 4th treatment, just yesterday, I've had probably my best session since starting, and it's been a continuous improvement throughout. Yeah, I would definitely recommend Shockwave for similar injuries. Yeah. Between doing the injury and the assessment was about 2 to 3 months, and in that duration I saw no improvement at all. Maybe just a slight decrease in pain since the acute phase. However, after starting the treatments, there was a continuous improvement.